Welcome everybody to our second Provider Plus web conference series, Health Market 2.0, Provider Plus Retailers, the New Front Door to Health, co-sponsored by Oliver Wyman and Foley and Lardner. Delighted to have all of you here today and to see so much interest in this topic. I think we're ready for a terrific discussion. I'm Sam Glick. I'm a partner with Oliver Wyman, and I'll be moderating today's discussion. We have four really great panelists with us today. We have Alex Hurd, Senior Director of Product Development, Growth and Payer Innovation for Health and Wellness at Walmart, talking to us from the retail side. We have Steve Lockhart, Chief Medical Officer of Sutter Health, talking to us from a provider perspective. Tom Beauregard, the Chief Innovation Officer of United Health Group, speaking from the payer perspective, and Alexis Bortnicker from Foley and Lardner, who'll be talking to us about some of the implications operationally and from a legal perspective of the growth of retail health. Before we get started, a couple of housekeeping items. For those on the phone who are attorneys and seeking continuing legal education credits, today's program will run for an hour and a half and will apply for 1.5 general CLE credits. Anyone wishing to receive credit for today's program must enter the codes when announced during the polling question, and Alexis will be the one to announce those codes. A box to enter the code will appear on your screen for approximately 30 seconds. Everyone seeking CLE credit must enter the code in the box on their screen at that time. All New York, New Jersey, and Kansas attendees applying for credit must also fill out an attorney affirmation form and write down the course codes. The attorney affirmation form in today's slides can be obtained in the resource list widget at the bottom of your screen. For New York attorneys, those of you with less than 2 years of experience will not be eligible to apply for CLE credit. Completed attorney affirmation forms should be emailed to Christina Wade, that's CWADE @foley.com. CLE certificates will be sent to eligible attendees via email in approximately 8 weeks. That, I promise, is the least interesting part of this entire discussion. We will start with an overview from our panelists of who they are and how they view the retail world, and in particular their retail health efforts. We'll then have, hopefully, a very vigorous discussion about some of the opportunities and challenges presented by retail health. And then we'll save some time at the end for questions from all of you in the audience. So questions can be submitted at any time during the conference. You should have a Q&A widget on the left side of your screen. And as time permits, we will answer those at the end. But I encourage everybody to submit questions as they occur to you, and we will keep a list of those and get to as many as we can at the end of the session. So with that, delighted to welcome our first guest, Alex Hurd from Walmart. And over to you, Alex.
Thank you, Sam. And thank you to the Oliver Wyman and Foley teams for inviting us to participate in this event. I really look forward to a phenomenal session. So my name's Alex. By personal introduction and background, my dad's American, my mom's Italian. I grew up in Germany. My wife is from Mexico, and my son grew up in Vietnam. I've been with Walmart for about 3 years and absolutely love it. I've had the opportunity to do a lot of different things in my career. I have worked for the Rolling Stones. I've been on the assembly line building cars. I've been an investment banker. I have not felt as professionally fulfilled since setting up pediatric AIDS clinics in Cambodia 10 years ago. I can tell you that it's awesome to be part of the team whose mission it is to be the #1 retail provider of affordable health care. And so let me talk a little bit about Walmart. Walmart is the largest retailer in the world, largest company in the world by sales, with over $480 billion in sales. Globally, we are in about 28 countries. We have 2.4 million associates, and we call associates our employees. In the U.S., we have over 1.3 million associates, and every week we welcome 140 million customers into our stores. Once a month, there about 2 out of 3 Americans will visit us, and on average spend about 40 minutes in our stores. If you think of Walmart, you probably think of the big box, the supercenters, which form a big part of who we are. But there's also exciting developments in other categories and other formats that we're driving. One is in the e-commerce space, where Walmart.com has evolved into one of the top 3 e-commerce and m-commerce platforms in the U.S. And then our small format neighborhood markets, which I absolutely love, because the focus for our neighborhood markets is really around fresh and health. And they allow us to serve customers in markets where historically we haven't been able to go, such as very rural areas, or in metropolitan areas like downtown Chicago or Washington, D.C. So let me pivot to Walmart and healthcare. I've shared with you our mission, and let me talk to you about our portfolio and our existing capabilities, as well as those that we're building out. And so within our existing portfolio and our existing capabilities, I'll break it down into 3. And I'll start actually with our pharmacies. So we have over 5,000 pharmacies across the country. Every one of our pharmacies does immunization, so pharmacist-administered immunizations, as well as medication therapy management. And we're staying true to our mission, from the very get-go. If you think of programs such as the $4 prescription program that was launched at this point almost 10 years ago, but to this day remains one of the more disruptive programs in the pharmaceutical space. The second current capability is around what I call our ancillary products. And so that would be over 27, actually at this point, we're over 3,000 vision centers across the country. And vision is actually interesting because it's one of the few categories where we're vertically integrated in the sense that we not only have the vision centers in store, but we actually have manufacturing facilities across the U.S. where we make the eyewears. And so what that allows us to do is drive tremendous value for our customers. But so our vision centers, our audiology centers, which our Sam's Club partners are, our Sam's Club division is aggressively rolling out, and we're now almost at 500 audiology centers across the country. And so, again, ways in which we're staying true to the mission on the vision side, I'll share with you pediatric eyewear, which we have at price points of $28. And so and then the last current capability is around really the direct-to-consumer health or over-the-counter medication, non-prescription medications. And here we're the largest provider in the U.S., and we've taken that position really to drive innovation for customers. And one example would be our private label Rely On brand, which is focused on really driving value for our diabetic customers by offering products such as the $9 box of 50 strips, which in many cases is lower cost our customers less than their copay for other branded products. So those are our existing capabilities, and then some of the newer capabilities that we're building out, and that I'll talk more in depth. I can talk more in depth later if in the presentation. One would be primary care, and so we launched a pilot last year in 17 markets across Texas, South Carolina, and Georgia, where we have introduced a new retail primary care model in stores where we offer full primary care staffed by nurse practitioners that are Walmart nurse practitioners overseen by local physicians or hospital groups, and offering, as I said, primary care and chronic disease management to customers at a $40 price point per visit and $4 for associates. And then the last capability is around health insurance distribution and health consumer engagement. And so we've launched an initiative called Healthcare Begins Here, really around educate. It started off as a platform to educate customers about their health insurance options, initially around Medicare, and then with the Affordable Care Act, we added individual and family plans, where we have agents that staff stores. This year we're going to be in about 2,500 stores, as well as a call center that's tied to those agents, and then a web portal where our customers can choose insurance and the right insurance for their unique needs in any way they would like to. And this past year, we kicked off Healthcare Begins Here with a health fair in 2,000 stores, where we brought in nurses to do health screenings and to do, and we had our pharmacists do immunizations. Well, we did 2,000 stores last year and broke 2 world records around screenings. And so we were so encouraged by the results that this year we're going to have a kickoff on October 10th in all stores. We're calling it America's Biggest Health Fair, where we are going to target 250,000 screenings as well as 100,000 immunizations over a 4-hour period. So October 10th from noon to 4, come visit us. I think it should be a phenomenal event. Thank you very much, Sam.
Thank you, Alex. Exciting stuff, and can't wait to dig in a bit during the discussion. Steve, I'll hand it over to you.
Thanks very much, Sam. So to introduce myself, I'm Steve Lockhart, the Chief Medical Officer of Sutter Health, and I will be speaking from the provider perspective today. And just by way of background, very briefly, Sutter Health is the largest contiguous not-for-profit health system in the United States. We're located in Northern California, and we're also extremely diverse. I think that's important in terms of the lessons we learn in the care that we provide for our patients. We have more than 100 languages, and we serve some of the richest and some of the poorest areas in the nation. If you consider our counties, such as Del Norte County, it's the second poorest in the nation, whereas I think we're all familiar with Marin County in California, which is the richest in the nation. So we also have urban and rural facilities. So we have a really diverse group of patients and a diverse group of situations in which we provide care. Also, nearly 1 in 100 Americans receive care at Sutter Health. We have 3.3 million patients. So I think that in that sense we have the ability to have a significant national impact in terms of defining care models and the ability to spread and share them with other providers across the country. So in that sense, we're a very good laboratory for change in healthcare. We're also a large economic contributor in every community in which we provide care. We have more than 50,000 employees, in our organization, and we'll talk a little bit in a moment about how we can leverage and learn from providing health plan coverage for our own employees as well. And finally, community impact. We provide 3 million of charity care each week, and importantly, in California, of course, our Medicaid program is Medi-Cal, and roughly 1 in 5, or about 22% of all Medi-Cal patients discharged from the hospitals in the counties that we serve, that care is provided by us. So when we think about the retail environment, hopefully there we are, get it to move forward. I think the members of our community who are our patients, it's important to remember that they spend about 1% of their time with us as providers and 99% of their lives doing other things, including building retail relationships that are very important to them. So our ability to connect on that platform is really quite powerful, and that's really what patients want. It's important to remember that, particularly in this new healthcare environment with high deductibles, there are a lot of services that patients consider to be shoppable, that they seek in the retail environment, and that's really based upon convenience and price. So access, convenience, and price are extremely important. And our patients, our Sutter patients, we know are already making these decisions. So we think our best strategy is to make this connection with the retail environment in a meaningful way. I'd like to briefly highlight two ways in which we're doing this. There are many more in which we're beginning to engage, but in particular I'd like to highlight a relationship that we have with CVS. As you know, CVS has been sort of reformulating themselves from a retail company to a healthcare company, if you will. And one of the services they provide are minute clinics, which are urgent care clinics. I'll be quick to point out that at Sutter Health we also have express clinics of our own, but we feel that we still need to engage a company like CVS that has a much broader retail footprint than we ever could. We've begun providing clinic oversight to the 14 Northern California minute clinics that CVS provides this summer. And importantly, we talked about connectivity. We have arranged for our Epic electronic health record. That's the system we have throughout all of our Sutter facilities, both inpatient and ambulatory facilities, that CVS will now share information with the patient's permission, obviously, between what happens in the minute clinic and also the Epic EHR. That'll allow us to provide a more continuous care and allows us to engage in care coordination strategies as well with CVS, for example, with medications and medication reconciliation. It's also an opportunity for us to engage in a growth strategy by providing care, or at least offering to provide care, to the large number of patients who come to these facilities who do not have a primary care provider. The second example that I'd like to highlight is in the virtual world with MD Live. With Sutter Select, which is our self-insured health plan, as I mentioned, we have 50,000 patients. We have been offering these virtual consults to our employees. And we have not yet expanded the platform to include primary care PCP visits, but we are providing urgent care types of visits through MD Live. And so far we have 15 of our own physicians who are providing those visits, and more are getting credentialed as we move forward. So I think in summary, and again I want to be brief to leave time for discussion, but I think it's important that we view this entire process from the customer viewpoint. And I think it's important to recognize that maximizing the patient's experience and looking at this from their perspective and making it less complex and providing connectivity is truly what's going to build our brand and also build patient loyalty. So with that, I'll thank you, Sam, and turn it back over.
Terrific. Thank you, Steve. And over to Tom.
Great. Thanks, Sam. And I'm Tom Beauregard. I'm the Chief Innovation Officer for United Health Group. And I would just say that as the largest payer, United Healthcare, and that's commercial markets, employer and individual, and Medicare markets and Medicaid markets, and through our Optum businesses, as an entity, we're very focused on sort of effective care and consumer engagement models, and have been for many, many years. But in the more direct-to-consumer space, the specific direct-to-consumer product space, that's an area where we have to accelerate our efforts, and the payer industry has to accelerate efforts because the markets are evolving. And some of that's related to healthcare reform, and very specifically the public exchanges and the growing interest from employers large and small in private exchanges. So just as an industry, I'll say we need new insurance products, new care models, and technologies that appeal to different consumer segments and produce both improved clinical outcomes and improved cost outcomes. So I will tell you that from an innovation perspective, we're really focused on that, and I'll offer up some examples in a few minutes here. But we really, at a more specific level, need solutions, and Steve touched on this, and Alex touched on this, that extend evidence-based care in virtual ways, appealing, affordable, and effective ways, and we need to link to existing retailers because we don't have that footprint and we don't have that sort of consumer reputation. So we need to design differently with consumer and provider insights. And I would just say that we recognize that there's a need for a patient-controlled delivery system, and we've invested and organized around human-centered design. So whenever we develop a new pilot or a product, we're doing really deep consumer and provider research to determine people's expectations before we launch. So in my slide, I just offered a small number of examples of direct-to-consumer care and product solutions that we've created at scale or we're currently testing. And they really break down into some basic categories. The first category is local direct care models that we offer across the country. So we have a growing footprint of physician practices and clinics that we've acquired. And really our intent with these clinics is, and primary care offices, is to extend them in a way that where physicians aren't just diagnosing and assigning treatments. They need to be in a position where they're educating, they're monitoring, they're coaching patients. And that is one of the areas where United and Optum, with our data and our technology solutions, we can enable that kind of a process. And we can improve patient outcomes, and we can drive more consumer volume to these practices, which is really sort of the rationale for the acquisitions that we've made in the provider space. The sort of second category that I focused on are much more specific direct-to-consumer product solutions that we've developed, and these range from sort of very basic HSA banking services that we've offered for years through Optum to much more advanced evidence-based adult weight loss models that we're launching, to models that offer consumers discounts for services that are traditionally not covered by the insurance model, through a new model that we launched in the hearing aid space called High Health, and then to another model that's actually in collaboration with Walmart, which is a sleep product that literally just launched in June. But this is a 6-week program off the shelf at Walmart that couples Optum advisors, sleep advisors, with a wearable sleep and fitness tracker and a behavioral therapy program to really ultimately teach consumers with insomnia how to relax and rest without pills or prescriptions. So that's just a very specific example of kind of collaboration opportunities where we can bring our clinical content and our expertise in the clinical area together with a retailer to offer specific consumer solutions. And then the final category that I have here, and this gets to my earlier comment on how we have to find ways to extend evidence-based care in more appealing and more effective ways, are these group models. So my team over the last several years has been doing a lot of work on group models that offer consumers with a specific health condition clinical content in a group setting, and that can be face-to-face or that can be virtual. And the 3 examples I have here, and there are several that we've worked on and continue to work on, but the first is a diabetes prevention program, which is a 16-week lifestyle intervention for pre-diabetics that has a lot of great evidence behind it that we've scaled through a partnership with the Y nationally. The second model is called Expect With Me, and this is a group prenatal care model that has tremendous outcome results in terms of healthy babies that we've been working on with Yale. And again, really strong results in clinical trial, and now we're piloting it in several different markets. And then finally, Join for Me, which is a childhood obesity intervention. And all of these models, whether they're group models face-to-face at the Y or they're virtual models, have had really strong participation and clinical outcomes. And I think the reason for that, the core reason, is because you're getting consumers together, again, either online or face-to-face, and there's peer support. So it's an efficient way to deliver content, but it's much more powerful than that 7-minute office visit. And there's follow-up support. And again, I think that the secret sauce in this is that the groups bond and they support each other through that health status and the change that's required. And just one more point in this, and it's kind of an interesting iteration on the group model that's worth mentioning, is we created a virtual solution a little over a year ago with Comcast and NBC in the diabetes prevention space. And what we did is we took 6 pre-diabetics, so not actors, and we basically filmed them, took them on air through the 16-week program. So there were 16 episodes of a reality TV program that delivered the clinical content, showed the live interactions, showed the struggles that these participants had inside the class and outside the class, and showed their clinical ups and downs through the course of the process. And this model was specifically called Project Not Me. We've used that in several different ways. So it's literally a reality program that has clinical content embedded in it. And we've used it in several pilots, and we're extending it to several other markets. But the whole idea behind this is that pre-diabetics, consumers, can watch the episode at home, and with Comcast in the model that we did, it was on demand, but there are other ways to do this. They can track their results with Bluetooth scales. There's an Optum coach that's available to them. And the end goal is to avoid crossing the line into diabetes. And we've had tremendous success from a participation standpoint and from a outcome standpoint. And I would say that that's really because it's convenient, right? It's on demand. It's evidence-based, so we know it works. But the most important piece of this is it's entertaining. People really enjoyed the format. They bonded with a particular character. And it's just, I think, a great example of how we can extend evidence-based care in really efficient ways. And then the final category, just to take another minute, that I'll touch on in the direct-to-consumer space that isn't part of my slide, but it's obviously critical to any consumer market, is transparency. So if you think about healthcare, the idea of any consumer market without simple, clear information on cost and quality is absurd. And in healthcare, we know there's massive variation in both cost and quality. So payers like United are clearly the entities that have this data. And I think what we're doing is making strong efforts to share it with consumers through our own tools. So we have a transparency tool called the Healthcare Cost Estimator. But probably more importantly, we're looking to take public efforts. So we partner with a not-for-profit called the Healthcare Cost Institute in D.C., along with Aetna and Humana and Kaiser, and pool our data and what we've created is a public transparency model. So the first version of this that HCCI launched was last February. It's called Guru, and there's more to come. But my point is we've got to get the data organized in a way that consumers can understand cost and quality differentials and that they'll use it. And within United, we're testing a series of solutions to encourage consumers on use of this public utility. And I just think it's a critical element when we talk about the direct-to-consumer space in healthcare. So I'll close there, and I'll turn it back to you, Sam.
Thanks, Tom. That's great. And excited to dig into kind of this expansive definition of retail care, because I think that certainly shares your view that bringing all these pieces together is what really creates the right consumer experience. But before we will do that, I will hand it over to Alexis to bring us back down to earth about what's really possible and what makes this hard.
Thanks, Sam. As you can see from our panelists, the movement of healthcare into the retail space is progressing at a continuous pace. From the concept beginning in 2000, when we saw the first retail clinics have grown substantially and are believed to have numbered over 1,850 clinics as of January 1st, 2015, up from just 1,600 a year earlier. And we continue to see headlines indicating growth in this sector. And the growth is not limited to retail clinics. As we just heard a little bit, there's been growth in several other sectors. There's been growth among traditional urgent care facilities, which are also aimed at providing convenient access and care at lower costs than traditional emergency rooms. There's also been a push towards the expansion of telehealth access and availability, with more states enacting legislation to allow for medical services to be provided through telehealth platforms, more insurers, including Medicare Advantage and Medicaid managed care plans, providing coverage for telehealth services, and new providers beginning to provide a range of services through telehealth, from web chats for middle-of-the-night ailments to expert opinions, to access to physicians who may not be available in the area. And additionally, there's been an increased spending from employers on employee health and wellness, and a new availability of healthcare and lifestyle services on location, whether that's health screenings, health coaches, primary care services on site at the job, smoking cessation. There's a wide range of activities being offered by employers. This move to provide care in a non-traditional setting can pair well with retail medicine and creates a huge opportunity for growth. And I think this is one area where retail health will increase its presence in the future. And finally, we live in a digital age where convenience and immediate response have come to dominate our culture and our expectations, and that's not just for millennials. The growth of personalized medicine and a new push and ability to track basic personal metrics is another area for potential growth and partnerships between retail and healthcare. I wanted to touch briefly on why retail health, why has it become so popular? For the patient or consumer who is seeking health care from retail providers instead of traditional providers, retail health provides first and foremost convenience. You can get your flu shot while you shop for groceries, or have someone check for strep throat at the local store without having made an appointment. In addition, you can pick up your prescription right there if one is needed, as well as other things you may need, like vitamins or detergent. And retail clinics specifically also offer limited wait times, if not instant access, making them much more appealing than waiting for your local provider. Retail health also typically provides a lower cost alternative. Traditionally, retail health allowed for access to care at transparent lower prices, as somebody mentioned. Price lists are handed to the patient on arrival if not readily posted, and often a patient could walk out having paid less than his or her copay at the local emergency room or even doctor's office. For a patient or consumer, this is really important, as that's how we do business on a day-to-day. Why not in healthcare? Additionally, retail health provides a sense of consistency. When you're traveling and something goes wrong, you can walk into your local drugstore and find a provider who can treat certain ailments. That's much easier than finding a local doctor or provider who may or may not be covered under your insurance. For the industry, there are also benefits to retail health. Initially, retail health provides an ability to standardize care. With retail health care providers providing typically a limited set of services, creates an opportunity to use evidence-based clinical protocols and push them through in a way that we know will have compliance, which might be harder to do in a traditional care setting. In addition, retail health offers market presence. As we see consolidation in the market, retail health is another way to expand the market footprint of a healthcare system or insurer. As care is being pushed out of hospitals, provider movement into retail provides an opportunity to recoup lost revenue and allows for a new point of access to bring patients into the system. And like other industries, retail allows for the effective foot traffic, and the ability to use the clinics to cross-sell other offerings creates an opportunity, whether it be the sale of pharmaceuticals, vaccines, vitamins, or other services that might not be so easily available to providers in typical settings. The move to retail health is not without opposition. Physicians and traditional providers, in a lot of cases, argue that care is becoming fragmented and there's no follow-up or real patient relationship. Others argue that the increased reliance on advanced practice clinicians instead of physicians can be detrimental to the quality of care. It's unclear whether any of this is true, but we'll see in a minute how some state laws have tried to address this. In theory, retail healthcare is an easy way for us to help achieve the triple aim of improved patient care, population health management, and reduced costs. For example, through retail health, we can have increased access by placing clinics in rural areas or places where we might not otherwise have access to care, reduce costs and convenience for population health management. So some question whether this has actually been achieved or whether the population served and the services provided actually create fragmented care and provide access only to those who already have it. So I think this is one growth area or place of expansion where we should expect to see some movement from retailers. I wanted to touch on the legal considerations or issues that have to be thought through when providers move into retail or retailers move into healthcare. Like most healthcare enterprises, the world of retail health is heavily regulated and can be a landmine if not navigated accordingly. The first issue that I wanted to touch on, sorry, I just realized my, apologize, my slides are a little bit out of order. But the first issue that I wanted to touch on is licensure and certification. Each state has its own approach to licensure and or certification for retail clinics specifically. And many states are still in the process of trying to figure out how to handle retail clinics or retail health locations. Some states, like Massachusetts, have created a new licensure category, acknowledging that trying to squeeze retail clinics into existing categories didn't make sense, because in order to meet those requirements, we would not be able to achieve the goals of easy access to care at reduced prices. And at the same time, they didn't want to leave them not licensed for fear that there'd be no ability to monitor. So Massachusetts created a separate category for what they call limited service clinics. Only specific services can be provided at the clinics, and they're enumerated in the regulations. The Department of Public Health maintains a nurse practitioner who reviews clinic policies and does site visits. This provides oversight and addresses quality of care issues that some people have criticized retail clinics for. Limited service clinics are also required to refer patients to PCPs and must have a process to identify and limit repeat encounters. Again, this goes towards the concern of physicians that care is fragmented and there's no follow-up. Limited service clinics are also required to provide copies of records to a treating PCP in order to allow for follow-up care. Not all states have taken the same approach as Massachusetts. In other states, retail clinics are required to get the full clinic licensure, or alternatively, in many states, they're operated as physician offices and not subject to licensure at all. This is very much still an open issue, with legislatures still addressing these issues in certain states, and an opportunity to influence the state of the market. In addition, as the scope of services expand, we see new licensure issues based on service offerings. Just as one example, when telehealth offerings are made available, there are new issues in each state which will govern what can be provided, where it can be provided from, and to whom it can be provided by. Telehealth comes with its own set of issues, so I will leave that for another day, but I do think we will see retail health and telehealth closely linked as we go forward. Next, I wanted to talk about ownership and structural restrictions. Now, again, this is a state-by-state analysis, making it complicated to roll out on a multi-state platform. The corporate practice of medicine doctrine dates back mostly to the early 1900s and prohibits the employment of professionals by corporations. That said, we've seen renewed, so even though it's an old doctrine, we've seen renewed interest in the doctrine in many states, such as Connecticut, who are reassessing whether or not it still applies in today's time. The doctrine has taken many forms in many states. Sometimes it's rooted in case law and others in AG opinions. Sometimes Board of Medicine rules or statutes. In some states, it covers all professionals, meaning that professionals cannot be employed by corporations, and that includes advanced practice clinicians. But in others, it only applies to physicians or a limited set of professionals. Most retail clinics are run and are staffed by advanced practice clinicians, so the question is, can a corporate entity employ these professionals needed to run and operate the clinic? If not, an alternative structure must be used. In Texas, just as an example, although it's a strict corporate practice of medicine state, the doctrine nevertheless doesn't apply to nurse practitioners, therefore allowing flexibility of ownership and structure, with the clinic being owned by a corporation and staffed by employed nurse practitioners while contracting with local physicians to provide supervision. In other states where physician participation is required, whether because the clinics are operated as physician offices or for other reasons, many have used the friendly PC or captive physician model, running both a physician-owned enterprise that provides the professional services and a management company that manages the physician entity. This creates some risk and uncertainty, first because the model is not yet really tested in court or officially approved, and also because there's a lack of direct control of the physician entity. But it's nevertheless a model that has taken hold throughout the industry and that we're starting to see used more and more for different reasons. Next, I wanted to touch about scope of practice restrictions. As I noted earlier, one of the most significant ways in which retail health has been able to successfully lower costs is by using mostly advanced practice clinicians instead of physicians. Each state has varying oversight and supervision requirements that will affect the operation of a retail clinic. The regulations can govern scope of practice, ability to prescribe, supervision requirements. They can limit the number of advanced practice clinicians that can be overseen by one physician, etc. Just a few examples. In Florida, for example, an advanced practice clinician is required to maintain a practice agreement with her supervising physician, and it also requires that the practice site of the clinician be within 25 miles of the physician's primary office. Florida also only allows a physician to supervise up to 4 offices. In Massachusetts, which also requires a practice agreement between the clinician and the physician, physicians have to review the prescriptive practice of the nurse practitioner every 3 months, and every prescription of a controlled substance must be reviewed within 96 hours. This means that the operations of a retail clinic will have to vary by state, along with the organizational or operational structure, and then often clinical oversight protocols cannot be used from state to state, but will have to be addressed on an individual basis. And of course, working within the healthcare system, retailers and providers need to remain conscious of fraud and abuse laws. First and foremost, when working in this space, especially if services are being provided to Medicare or Medicaid patients, one has to keep in mind the anti-kickback statute. The federal anti-kickback statute prohibits the offering, paying, soliciting, or receiving of any remuneration in exchange for the referral of Medicare or Medicaid business. This is a criminal statute that comes with severe criminal penalties and fines. If a retail clinic is providing services to Medicare or Medicaid members, it must ensure that the relationships are structured in a compliant manner, whether within a safe harbor, if one is available, or otherwise. This law particularly comes into play when a clinic is owned or is not owned or operated by the host retailer, as there can be arrangements that implicate the statute. As a result, the host retailer needs to avoid paying any remuneration for referrals, and similarly, a retailer should avoid any revenue-based lease arrangements, which are often standard in retail space. The risk can be mitigated based on proper structuring, and there are certain exceptions that are safe harbors within the anti-kickback statute that can be used, but it's something to keep in mind when structuring relationships. Another law to consider, especially if Medicare services are being provided, is the Physician Self-Referral Law, or Stark Law. The Stark Law prohibits physicians from referring patients to an entity for certain designated health services payable by Medicare or Medicaid if a physician or family member has a financial relationship with the entity. The Stark Law only comes into play if designated health services are being provided. And traditionally, most retail clinics don't provide designated health services, so this is not something they've had to worry about in the past. However, as retail clinics are becoming more full service and lab services and radiology services are beginning to be offered, this will become an issue. As that becomes the case, arrangements will need to fit within the Stark Law exceptions, as Stark is a strict liability statute. Additionally, one cannot forget that even if services are not provided to Medicare and Medicaid patients, state laws may extend similar statutes to commercial payers. Finally, I just wanted to touch briefly on a few other things that are to consider. First of all, if services are being covered by commercial payers or state or federal healthcare programs, then clinics will need to meet credentialing requirements, whether that means certification, participation in Medicare and Medicaid. Meeting these requirements may be essential for success as more people have insurance coverage in order to ensure there will be a source of payment. I also wanted to note that retail clinics and retail health providers in general are subject to state and federal privacy and security laws, including HIPAA and its implementing regulations. For retailers not already in that space, it may mean new systems and security to meet those requirements. And finally, I just wanted to mention quickly that there are state and federal laws that govern the marketing of healthcare services. These vary based on the services offered and the population targeted, but retailers who do general advertising will need to consider requirements as they enter into this space. So to wrap up, so we can get back to our speakers, I just wanted to touch on some areas where I think we can expect to see growth in retail health in the future. First, I think we will see retailers move into chronic health management and population health going forward, in partnership with both providers and payers. Retail health providers are in prime position to provide these services given their proliferation and convenience. And additionally, I think we'll see more expansion, as Alex noted, into provision of full primary care services and not just limited services. Second, I think we'll start to see more interconnectivity and information sharing. As we see more partnerships with providers, the ability to share information will help address some of the concerns about fragmented care and will give primary care providers a better understanding of why patients are going to clinics and providers at retail clinics a better picture of the health and history of the patient. Third, and I touched on this already, but I think telehealth expansion and retail health complement each other and will likely develop hand in hand. Fourth, and I also mentioned this briefly at the beginning, is employee health. As employers move into the health and wellness space, retail clinics are prime locations for the provision of some basic screenings and other services in a cost-effective and efficient manner. And fifth, I think we'll start to see more payer partnerships. And as payers begin to enter the game, they have the potential to change the space. And with that, Sam, I will turn it back to you so we can get back to our panel.
Terrific. Thank you, Alexis. And I think that's actually a great tee up for some of the discussion we're going to have. My first question, just reflecting on the introductions that people just made, is for you, Alex. I think as everyone's highlighted, we've seen tremendous growth in retail care. The dominant player in this space so far has been CVS, just in terms of their Minute Clinic, both their brand and their expansion. But if I look at, slightly under 2,000 retail clinics so far, 65,000 or so retail pharmacies in the U.S., I guess it's kind of a two-part question for you. One, how much growth should we expect to see over the next several years? How big do you think this gets? And then two, specifically for Walmart, when I look at the kinds of logos on this page, how do you think Walmart's strategy is different from some of the types of customers and types of offerings that either the chain drugstores or the Targets or the others of the world might be going after?
Great questions. And maybe I'll start with the second one, Sam, first.
Please.
And so, and I'll give a little bit of background of how we decided to go with primary care and to offer primary care in in the Walmart Care clinics, because there's actually a ton of research that went into that decision. So, look, what we started off by looking just at peer countries and looking for best practices. And now, granted, it's I don't know if best practice is the right term because every system around the world has its own issues. But as we went around and looked at peer countries, and keep in mind, we spend 18% of GDP on healthcare, whereas in Western Europe and Japan, I think it's in the high single digits. And so clearly, there are ways to do healthcare at lower cost. And so we looked at what are some of the practices out there, and what we seemed to find was this notion of a well-established primary care network that could detect or that detects early on issues and avoids in doing so can avoid escalations. And so what we then looked at, was, what could be barriers in the U.S. for Americans accessing the primary care network? And we did a lot of research, and I'll oversimplify this again, but we really landed on three areas, and Steve touched on these before. And so the number one was cost and price. And so we looked at a study done by one of the big research firms that looked at 2012 or 2013 and found that over 50% of consumers deferred healthcare due to cost. The second area was around access and geographic access. And I think there, again, I don't know if it's Milliman or one of the other big research groups, I think found that 30 million Americans lack geographic access to primary care in terms of distance. And the third point, though, was, call it convenience. I think, Steve, you call it convenience. I call it practical access. You have geographic access. Practical access is the fact that, let's say, you have a primary care provider close by, but, typical hours are 9 to 5, and if you, work full-time, your spouse works full-time, and you need to go take your child, for example, for a doctor's appointment, it becomes impractical, right? And so we looked at those three areas, and then we approached our consumer insights group, and we said, can you help us do a little more research on that? We want to dig a little deeper, and they did a survey for us, and it was, again, very simple. We asked two questions. And the first question was, do you have a primary care provider? Yes or no? And what we found was 53% of folks that responded came back and said no. And but then with let's say the other half, we went back and we asked, have you visited your primary care provider in the last 2 years, and or can you name them? And the response again was, 50% said no. And so, what that showed us, to summarize, is that you have a large proportion of Americans not accessing primary care. And so that really drove a lot of our thinking around expanding the scope and really doing full primary care in the Walmart Care Clinics. And after the first year of running the pilot, the responses have been very encouraging. And what we have found, actually, two stats I can share with you, is that 49% indicated in exit surveys that they did not have a primary care provider. And I believe 28% of visits that we have recorded are repeat visits. And so, it's really doing, at least in this pilot, what we set it out to do. So that's a response, Sam, to your first question. The second question, the second question. The first one, should we expect a lot of growth, and what is that growth going to look like? I'm not gonna put a number to it. But I do think that we should expect an expansion, and a pretty dramatic expansion. And if you look at healthcare right now, and we joke around the office a little bit, the current system takes a field of dream approach. Build it and they will come. Whereas with retail, the footprint, the facilities are already there. The consumers, frankly, the patients are already there. And as we look at population health management, for example, Alexis touched on this, if they're already with us, encouraging, asking the consumer, asking the patient to do just a bit more is just a bit less of a stretch, if you understand what I mean. So I hope that answers your first question. I do think we'll see a dramatic increase here over the next few years. Hard to say, in terms of numbers, what that'll be.
Got it. No, thank you, Alex. That's great. and lots of questions jump to mind as you think about that, but one that kind of immediately comes to mind, maybe Tom, is for you, which is one of the things that we saw in the early retail clinics was that they were very good at providing kind of one-off care, disconnected care, and they had a billing model that looked like that. They were sort of cash pay, and they weren't really connected to the traditional payer system. If I imagine a world like the one Alex describes, where I'm able to get my primary care at a place like Walmart, I need Walmart able to actually bill my payer for that. I need Walmart to be submitting claims to the data warehouse. How far along are we there, and what are we going to see over the next few years in terms of actually integrating this retail care with the quote-unquote traditional system?
And I would say that's the key to growth, to your question, in terms of, and that's, we're specifically in the business, the clinic business, the primary care practice business, the urgent care business, and we're all in agreement to Alex's points that there's a lack of sort of meaningful PCP relationships. There are long wait times for appointments for people that have that relationship, which then drives utilization down, and there's not enough incentive then in the system for preventive care, which has a long-term return. So really the growth has to come when you have access like Walmart's providing or Optum is providing, and connections to coverage with incentives for use. And I think that's where we're headed pretty quickly. And that's where it's sort of at the macro level, we'll see the right level of utilization in these primary settings. And that's really, there really is this absolute need to make these part of the network, to integrate it, and to even go beyond that and offer consumers incentives for use for preventive care in rewards programs.
I agree with Tom. And Sam, sorry to I agree with Tom. And the other thing that a enhanced and increased engagement at that primary care level will bring you is, at the macro level, a reduction in cost, right? Because you can reduce costly escalations.
And then the other point I'd make is these are also settings where ultimately these group models can be, you can aggregate patients based on health status. You can give them sort of voluntary election into group models. I mean, it goes beyond sort of day-to-day care. It's an easy appointment. It's these clinic models can actually be settings where group solutions, to the points I was making on models that we're developing and continue to develop, can take place.
Got it. And Alex, are you taking reimbursement from either the government or any payers today, or is this all cash pay in the clinics you have?
So at this point we have the 17 clinics open, and for the pilot, the initial focus, frankly, was standing them up, opening them up, and we're in terms of a contracting. From the contracting perspective, this is a new muscle that we're building. We have a large contracting team that is very good at like pharmacy-related contracts, and now we're coming up to speed on provider contracts. And so the prioritization that we have done is we've closed contracts on the fee-for-service Medicaid side, fee-for-service Medicare. Now, the next prioritization is going to be around managed Medicaid, as well as managed Medicare type plans, and then gradually grow that. But so absolutely, the idea is to contract with payers as we expand.
That's great. Now, Steve, if I hear this story from the perspective of a big health system like yours, I can take it two ways. On one hand, I think about the mission you described and the ability to reach some of the most remote and poorest areas and areas where people don't traditionally have access to primary care. Retail care like what we've just described sounds like absolutely supportive of the mission. On the other hand, if I'm an established primary care doctor and Walmart's now in my backyard charging a third or a fourth of the price, I may get a little nervous about my livelihood. How do you think about sort of retail fitting into, what has been a relatively traditional primary care model in this country?
Well, I think you point out the struggle that we have by having, the crevasse and one foot on both sides, right? So obviously some of our physicians do get a little nervous about, having us have a relationship with CVS. Is that going to take patients away, or even our own express care clinics? And of course, others say, hey, this is an opportunity for growth, so I can go and help, staff these clinics and maybe, find ways to improve and enhance our patient base. But I think the reality is that no matter what, patients they're voting with their feet already. So it's about trying to hold on to an old paradigm. I mean, I remember one of our hospitalists, I was talking to him, and he, just a very brief story, but I think it illustrates the point. He and his wife were home. His mother-in-law came in, said, I can take the kids. You can have a date night. They said, great, on the spot. By the time they hit the door, they had an open table dinner reservation. Uber was on the way. They went to dinner, and they were talking about his health and mentioned that he needed to fill his prescription. By contrast, that required a phone call, an appointment the next week, going into the pharmacy. So at some point, folks just don't tolerate that kind of disconnect where the majority of their lives can be managed very quickly and easily, and this part cannot. So I think we're already there. I think the physician community has to realize that. And one of the barriers we have, and I think that was discussed in the presentation a little bit as well, but is the payment models for physicians don't match up with what the patients really need and with the whole idea of, managing population health and total cost of care. So physicians still are getting paid on RVU basis. So, the more RVUs you generate, the more you get paid. If I don't see patients, I don't get paid, as opposed to how can I connect and coordinate the care of my patients with some of these other retail facilities and other options that we have. We have, on the other end of the care, we have a lot of, home care, hospice, other types of options that we need to connect our patients with, but the physicians are not reimbursed that way. So it's a struggle. I think at this point for Sutter Health and our physicians, we're trying to really stay focused on the mission, but it does become an uncomfortable conversation sometimes.
No, I'm inclined to agree. There's a bit of embracing reality in this one, putting the consumer first. To that point, Oliver Wyman last year fielded a survey of consumers across the country regarding retail care. And what we found was that, and people can see the stats on the screen, but that there's, roughly 2/3 of Americans are familiar with the concept of health and wellness clinics within retail stores, but only 15% of them or so have used them. And those numbers even scale down more for remote care like telemedicine. And so, Steve, I'd be curious, as you are just now launching this partnership with CVS and the Minute Clinics, to what extent and how are you doing patient education and patient engagement to actually drive traffic and connect people to those stores? Or are you really relying on the retail traffic that's already there to then bring people into Sutter Health?
At this point, we're, really, to be honest, we've really kind of relied upon the retail traffic component, but we are developing education for patients, and particularly education for patients who already are part of Sutter Health, certainly to let them know that, should they go to a CVS clinic, particularly the things that they're interested in are that their health records are connected, and that we have the ability to connect their care both on the retail clinic side and also on the health provider side. So we're starting to work on how do we develop a broader education for consumers as opposed to education for people who are already patients in Sutter Health, and we haven't quite gotten there yet. But certainly our Sutter Health patients, we have educated them about this opportunity, which, as I mentioned before, is a little bit tricky and can be a little bit uncomfortable because, we're basically telling our patients that they have the option to go to seek care in these other environments when we have our own express clinics and we have our own physicians who have, maybe extended hours and so forth that they're trying to. But I think, again, coming back to looking at it from the patient perspective, they want choice, they want options, and so I think we're wise to be connected with them, those options strategically, and to go ahead and acknowledge and support our patients who choose to go to these retail environments.
Got it. And Alexis, as we have both other providers, but also retailers and payers on the phone here, thinking about these partnerships and all of the issues, the complex economics that I see around whether you're driving people to stores or not, and the retailer certainly makes money on much more than just the clinic visit and getting scripts filled in that store, and all of the kind of the complex economics of this visit. What do they need to watch out for when in terms of kind of thinking about how to structure these partnerships and kickbacks and all of those issues?
Sure, and I think the biggest thing is sort of percentage of revenue of sales of things other than what's being provided directly. Anytime that you're getting lower lease prices or additional revenue based on number of people who come in, it's really the tit for tat payments that are becoming a problem, and that need to be watched out for, because as revenue is driven on one side and it's largely based on a relationship that may be beneficial to one person or the other to bring those people in, that's where we start seeing fraud and abuse issues.
Got it. That's helpful. And I think now we have a code for people. Is that right, Alexa?
Yes. Thank you, Sam. So for those people, this is just a quick housekeeping matter, but for those people who've requested CLE credit, this is your opportunity to put in the first code. And that first code is 5, N like Nancy, B like boy, S like Sam, C like cat. Again, that's 5, N like Nancy, B like boy, S like Sam, C like cat. You can go ahead and put it in the screen that's in front of you, and I will read it one more time. That's 5, N like Nancy, B like boy, S like Sam, C like cat.
Great. Thank you.
Thanks, Sam.
Tom, I have a question for you on this. I'm kind of thinking about the complexities and the different stakeholders that have to be engaged. I think, we've certainly heard a story so far today that retail care really is about thinking with the consumer in mind, and when we do that, we can actually expand access, we can have better outcomes, we can reduce cost of care, and we can engage people. But I think, we've heard from both Steve and Alex the importance of having the right partnerships with both local providers as well as payers. There have been some provider groups, particularly industry associations, that have come out pretty aggressively against the kinds of innovations that you listed on your slide that United Health Group is putting forth. The American Academy of Pediatrics advised parents against sending their kids to retail-based clinics. The American Academy of Family Practice says that retail clinics should be nothing more than urgent care, and that they oppose the use of them for chronic care. As an organization at United Health Group that has to deal with all of the players, right, consumers, providers, and new kinds of partners, how do you manage this, and how do you talk to your network about this?
Yeah, I would say that the way we manage it is you don't supplant the treating physician in this process. In fact, you make sure that you have you share data and you have technology apps where the treating physician is kept in the loop as care is received in different settings. And that's a really general statement, but I will tell you, you mentioned the pediatricians. I mentioned the childhood obesity intervention that we created called Join for Me. And the number one source of referrals for that group program, which was run by coaches, not physicians, with evidence-based content, was pediatricians. And so in many instances, the docs are looking for solutions because they actually don't have the time for interventions that take months and months, and they don't see their patient often enough to actually make that happen. So I think that it's really just positioning these models as ways to deliver content and making sure that we stay connected to the treating physician. And in fact, even encourage individuals, to a point that Alex made earlier, who don't have a PCP relationship to establish one. So, and that's not just us being careful in terms of the network. That's just rational care, and it makes sense from a consumer standpoint.
And I just want to note that when this matter has been legislated, when states have been trying to determine how to license sort of retail clinics, this is something that they've tried to sort of push through from a legislative point. Whether or not that works, it's unclear. But in order to sort of appease all sides, and that's where Massachusetts, for example, requires clinics to have a list of PCPs that they can refer you to, and tries to limit sort of repeat customers who should be having more follow-up care, and sort of forcing interaction between primary care providers and some traditional retailers in hopes of sort of appeasing some of these concerns.
Got it. Hey, Alex, on this topic, I'd be curious, in the 17 stores where you have clinics for Walmart, how you've engaged providers. I know we heard from Steve about a direct partnership between Sutter Health and CVS. I guess kind of a two-part question. One, how are you engaging providers and working with the local health system? And then two, to the extent that your vision is actually a pretty aggressive one, which is to provide not just urgent care but actual primary care to the 75% or so of Americans who don't have it. Where is that line between what Walmart wants to be doing in stores versus where you want people to be going to the local health system?
Great. Thank you. Excellent questions. So to the first question, how are we interacting with local providers? Let me just clearly say we can't do this alone. And there are no illusions here and no intentions to going about it alone. I think it serves nobody. It certainly doesn't serve Walmart to try to compete, frankly, with local systems. And honestly, in the markets we're in, it really has been, the response has been very encouraging, because I think everybody generally sees it as a genuine entry and access point for individuals that have historically not engaged with their health and not engaged with the health system, right? And so how we're going about it, I mean, I'll give you so there is a formal a process and a formal relationship with an overseeing a physician or hospital system or physician group that occurs market by market, clinic by clinic, right? But what we're also seeing is like informal relationships. And I'll give you an example. In one of our clinics, in one of those markets, there is there's a story where there was an ER, a 5-minute drive from one of our clinics, and at the ER they actually had the Walmart Care Clinic flyer, and they were sending people to the clinic if folks were coming in and clearly they thought that they didn't need to be in the ER. There was this informal referral process that is occurring. And so what we're seeing is just a general acceptance, and because what we're doing is really going into each market and explaining what we're trying to do, and looking for partners that are aligned to the mission, right? And then how do we want to grow that and interact? That, going back to my first point, we can't do this alone. We're looking for partners. And so, we think that with the nurse practitioners, you can do probably about 80-85% of primary care. But then when it comes to very complex cases, or when it comes to specialist referrals, we need to have those formal networks in every community, because it's in the patient's interest. And so that's how we're looking at it. We want to do what's right for the patient, right? And we will, in each market, seek those partners that are aligned to that mission.
That's great. And to that point, Steve, I'm curious, sort of when you were looking for a retail partner, what criteria did you use? Certainly, you had multiple options in Northern California. How did you think about finding a good fit for Sutter?
That's a good question, Sam. And I must admit I was not as directly involved in some of the discussions initially when we looked at this, but clearly, geographic spread, market penetration, being able to have sort of one relationship that covers all of the areas that Sutter Health is involved in is important. And then I think also having a partner who, not that CVS is necessarily the only one that fits this criteria, but having a partner that, our communities legitimately see as a, provider of healthcare services in some sense. And, CVS through their, retail pharmacies and so forth, and now their minute clinics has really made an effort to move into the healthcare space. So I think those are, both having a brand legitimacy that we felt comfortable, associating our brand with, and also having geographic and market penetration was important as well, because we don't want to be offering something across Sutter Health that only part of our network is able to access. So I think those are the primary characteristics. And then, of course, the willingness and ability to really partner both with the transfer of information to the electronic health record, but also, as I mentioned, we really are, also have our physicians providing some clinical oversight in the clinics as well. So that gives us a real comfort level around the quality of care and, the type of care that will be provided in those environments.
Got it. No, it makes a lot of sense. So moving on a little bit, Tom, I have a question for you. I think we've talked mostly today about primary care as a kind of physician or mid-level practitioner. But if I take a consumer view of the world, particularly in a world that's moving to value and focused on population health, for many consumers, primary care can be a combination of retail and telemedicine, but also, somebody who's a kind of comprehensive care team for my chronic conditions, helping me make lifestyle changes, or a health coach who may be helping me think about lifestyle changes. It could occasionally be that ED visit that I can't avoid. It can be, kind of any number of things depending on my health status and where I am in life. And so, when I think about where an organization like United Health Group sits, at kind of the middle of all that data, and with great ability to direct people to particular types of care, and the kinds of investments you've made kind of across this puzzle, how do you think about stitching all that together? Who's well positioned to do that? How am I helping consumers decide what care to get when and where?
Yeah, and I would say that's still the primary care physician relationship, however we define that, right? So as we're talking today about how that's extending to sort of other kinds of clinics, you need that trusted source. And I would honestly say that's, it's a big reason why we're investing heavily in the primary networks, through Optum. And it's that will continue to be the source. Now you need sort of the technology solutions and you need evidence, but ultimately I would say that PCP and it's getting to be a broader definition will continue to be the quarterback.
Got it. And kind of with your innovation hat on, we've got a question here from Randy Matthews, and I'll paraphrase it, Randy, if it's okay. But I think there's one view of this that says we need a full puzzle, and we're going to need the full puzzle for a long time, and it's about the right care at the right time in the right place at the right cost for a particular consumer's needs. I think there's another view of this that says, retail care could just be a transitionary offering, and that we're really going to move to more and more virtual offerings, and this is a little bit like Netflix mailing DVDs for a while until it gets the full streaming offering going. Do you think retail care is here in a kind of bricks and mortar sense for the long term, or somewhere on the horizon is almost all primary care virtual?
I guess my answer would be that it's part of the puzzle. but I also don't think it's a temporary part. I think retail care will will continue to expand as we integrate it with the insurance models and offer consumers incentive to use it. But then I would also say that the virtual models, as they evolve, the group models, as they evolve, these are just different kinds of delivery mechanisms that will all be part of the puzzle.
Yeah, I mean, I think you call it puzzle, or ecosystem is another word, right? I think there's room for every single part and every single player in that, including traditional hospitals and traditional providers.
Yeah, I would agree with that.
Right. Yeah, I might make this is Steve, I might make the observation that very much like in the publishing industry, where we went from books to e-books to now self-publishing online, the real reality is that represented the fact that there were authors and there were readers, and whether you have a physical book that needs to be published, yes, that can go to an e-book and then gets totally reimagined to where it's just simply self-publishing and online connections. I think this is the same kind of idea where we have our patients and we have the care that they need on the other end, and pretty much everything in between can be reconfigured, and probably will be over the next 5 to 10 years, I think, in very disruptive ways. So I'm not sure that I would place bets on any one model being the model, but I think it's going to be an evolution that will go through virtual and maybe even beyond.
Yeah, and I would just add, I mean, we're saying the same thing, but we need these multiple access points that connect through consumer health records and meet different consumer segment demands in terms of how they want care delivered, and not just sort of their preferences, but also their health status.
Yep. And on that point, Tom, if I throw up a chart here, but struck by your comment about consumerism in your introduction, and sort of how we have to be thinking about retail health as part of a broader shift from healthcare really being about group decision making to individual decision making, and that balance of power changing. And I think many of us on the phone know this stat, but this year is the first time when the average commercially insured patient in this country is in a high deductible health plan, which means they're paying the majority of their own health care costs in most years, and that changes their behavior in pretty material ways. And we've got a question here from Steve Flamingo that I think gets at this, which is, on one hand, I can think a lot about total cost of care and cost to the system as really what we need to be focused on from a population management perspective. On the other hand, there are some things to which consumers are disproportionately exposed to the costs. Primary care being one of them if it's not preventative, but also things like prescriptions where the consumer share is much greater. How do you think about kind of balancing efforts between really taking total cost out of the system from a population health perspective versus responding to the increasing cost share to consumers and helping them find low-cost options for the things they do pay for, even if those may not be the big ticket items like hospital stays?
Yeah, and I think that gets to sort of the transparency theme that I raised. It's we recognize that consumer out-of-pocket exposure is meaningful, right? Whether it's public exchange, private exchange, individual coverage, employer coverage, it's meaningful. And we also know that cost variation for a lot of what I'll describe as shoppable services within a catchment area is broad, and that there are quality differences. And so the macro level answer is we need public data on cost and quality that's available to the consumer in simple form. And then beyond that, because they do have out-of-pocket exposure, we probably need to design around it ultimately, and give people incentives to use that data as long as it's credible and clearly vetted within the the insurance designs that we offer up in the future.
Yeah, I would agree that transparency is definitely a key factor here, and it's
what patients want, and I think that we have an opportunity as well, even certainly in health systems like ours and so forth, to make sure that it's not only transparent but consistent across different sites of care, and different types of that the same treatment options are actually priced and cost the same across the system in whatever venue they're given.
I would just add, when I'm describing transparency, it's not just cost, it's other patient experience, it's volume experience, and it's public quality measures that again we need to put in the consumer's hands in digestible ways and offer them incentives to use.
Right.
Any other product or service outside of healthcare, Sam, there's a price list, and you go to the store and you know exactly what your groceries are going to cost you, and so I think we are so used to. I mean, we take it for given in any other market. It's kind of mind-boggling that we don't require it and we don't push for it in the healthcare space, and I think to your point, as more cost is shifting to consumers, more and more you hear more and more voices and more push for this to be just more clear and easier to navigate.
And there's real movement here. I mean, CMS is moving in this direction. Clearly, the private sector is moving in this direction. We need to aggregate credible data and put forward public utilities.
Yeah.
And if you go to the other thing about the care clinic, Sam, the other example I'll give you, I mean, not only is it $40 and $4, right, but then also if you go in for lab exams, there's some labs we do in the clinic point of care, but then and some that we send out, but we will tell you exactly, these lab tests will cost you $4. I think the price points are $4, $8, and $15. Right.
Yep.
And so it's just
hey, Alex,
clear.
I'm going to have to cut you off because we're going to lose the line. But I think that's a terrific set of parting thoughts. We didn't get to all of the questions, but we'll certainly follow up with people individually. For those on the line going for continuing legal education, I'll let Alexis give the final code now.
Sure. The final code is 3O like Oscar, I like igloo, O like Oscar, D like dog. Again, that's 3O like Oscar, I like igloo, O like Oscar, D like dog. I'll repeat it one more time, and then we'll leave the thing up so that people have time to put it in. But it's 3O like Oscar, I like igloo, O like Oscar, D like dog.
Well, in close, while people are doing that, I want to thank all of our panelists. I think it's a terrific discussion and one that could go on for many more hours than we have scheduled here. If you have specific questions, go ahead and put them in the Q&A box. We'll do our best to follow up with everyone afterwards. And, just in reflecting on the conversation today, I think that the kind of folks that we have on the phone, and Alex and Steve and Tom and Alexis, are in charge of building Health Market 2.0. We're in very good hands, so I'm coming away pretty optimistic. So thanks to everyone, and please join us in a couple of months for our next Provider Plus conversation.